6 months, over 6 million cases, almost 400,000 deaths. This is the story of how one virus made humanity question whether they were the ones in control. In December 2019, a novel, very contagious single-strand RNA virus appeared in Wuhan, China, the SARS-CoV-2 virus. We soon realized it caused COVID-19, characterized by respiratory illness and severe pneumonia, especially within the elderly. The virus rapidly spread throughout the world. By March 2020, we were living a global pandemic. At this point, in average, every infected person spread the virus to other 3 people. This is what we call an effective reproduction number, R, of 3. It was spreading exponentially, and so were the deaths from COVID-19. In order to control the pandemics, it is necessary that the R number is pushed below 1. Different countries have different curves. Why is that? This didn't happen synchronically for every country though. The virus arrived first to Spain and then to the US. Once in a new country, the exponential death counts would reach more or less a stunningly high value, depending on several factors. In this video, we aim to compare the situation of Spain and the US, 2 very different countries, in order to answer one question. Which factors can better explain the differences in the CFR seen between these countries? For Spain, 11.34%, and for the US, 5.82%. The case fatality rate measures the risk of dying from COVID-19. It is calculated using the number of confirmed deaths and confirmed cases of the disease. However, this rate depends directly on the number of tests performed by each country. We hypothesized 3 factors to explain the differences in the pandemic development between Spain and the US. We are just about to prove their relevance. The age of the patients and the presence of relevant comorbidities at different frequencies between the countries, the arrival of different viral strains to each territory, and the enforcement of state policies. Increased age is highly associated to lethality in patients with COVID-19. The highest mortality rate is seen in people over 70 years old. By comparing the population pyramids of Spain and the US, we discarded that the differences in the death were due to a higher frequency of elderly in one of the countries. Both countries display a similar proportion of elderly. We also know that the majority of patients who end up dying from COVID-19 have at least one previous pathology, being the most predominant comorbidities: cardiovascular disease, diabetes, hypertension, and chronic respiratory disease. By the same rule, we studied whether the risk of dying from COVID-19 could be affected by the prevalence of any of these medical preconditions. We found that even though hypertension is more prevalent in the US, major pulmonary diseases are more frequent in Spain than in the US. Moreover, diabetes incidence seems to be similar in both countries, so these factors do not explain the different number of deaths. The prevalence of individual comorbidities is differently distributed in both countries. However, both have risk factors. These results indicate that the epidemiological distributions of age groups and comorbidities are not sufficient to explain the differences seen in the CFRs. Secondly, we studied the impact of viral strains. Several mutations have been described to potentially modulate the virus capacity of transmission. One of them is G614D mutation. It stands out for being the most famous and, more importantly, increasingly frequent each day. This mutation is located in the gene of the S protein, essential for the entrance of the virus into the target cells. The punctual change of the amino acid glycine, a polar to aspartic acid, negatively charged, seems to have an impact on the viral transmission. The mutated form is replacing the ancestor strain worldwide, as shown in the map. Nevertheless, facts evidence that the mutated strain was introduced almost at the same time in Spain and the US, around January 21st. This being the case, even though popular, the arrival of the D614 viral strain does not significantly explain the differences in the transmission and the CFRs between Spain and the US. Spain has a public healthcare system that covers 99.6% of the country's population. Unlike Spain, medical coverage in the US is mainly private, and the public services only cover around 34% of their population, leaving 2/3 of the healthcare to private institutions, most of them provided by employment contracts. This results in a lack of hospitalization services for people that are not privately insured. This hits hard, especially at the elderly, since they are the most vulnerable group dying from COVID-19, and the ones that need the most medical services. These differences in medical coverage could explain why, although the global CFR is higher in Spain, in the US the CFR is higher in the age group of 65 years old and above. Until a vaccine is developed, the only way to reduce the CFR is to restrict personal contact. Both Spain and the US have implemented social distancing measures, but in different ways. So how is it possible that the contagion curves has elapsed in a similar way? In Spain, the containment measures were very strict and quarantine was established for everyone. In the US, however, the policies enforced were very different depending on the states, and only those who imposed more restrictive containment measures could stop the spreading significantly. As we can see, the contagion curve of the US changes when we exclude New York City's data in the epidemic curve. Surprisingly, despite the restrictions, we observe a positive correlation between the distribution of people with lower income and COVID cases among the poorer boroughs of New York City and Barcelona. We claim that this higher incidence of COVID-19 among lower income people is due to their inability to comply with the lockdown encouraged by economic needs. In conclusion, the different CFR between Spain and the US cannot be explained only with the three factors we studied. The only one that seems to exert a dominant influence is the set of policies enforced by the governments. Our research proves that state policies partially explain the differences on the risk of dying from COVID-19 between Spain and the US. These results highlight the importance of having a proper public healthcare system with enough resources to ensure the health of every citizen and not only benefit the private ones. Thank you very much for your attention, and we hope our work made you rethink the complexity of a pandemic and the importance of public healthcare. Stay home.